want to say thank you very much, David, for not only introducing me here, but also making this trip possible. I had official work in Canada, and the travels, the accommodation were arranged by the organization which I work for. We've been friends with David for some years, and when I mentioned that to him, he arranged that I come over, and I am so appreciative, David. Thank you so much. And I want to say thank you very much to everybody who is here. You know, in my culture, we say, if you prepare a meal and nobody comes to the meal, it's not, you don't get a good experience. So I'm really appreciative that you people are here to listen, and I hope to share after some time. Now, one of the little things that I would have mentioned, in addition to what David has just mentioned regarding my life, in Uganda, when we are introducing ourselves, normally we talk about whether we're married or not, whether we have children or not. And I want to say that I'm married. My wife is a teacher. I just spoke to her this morning after about 2 weeks. We have 2 sons. One of them is Joseph, who's a friend, who's just finished a bachelor's degree in mechanical engineering. And the second one is just making 6 years in a few months. So we have those 2 boys, and we're grateful. So I will just go on to, maybe I want to mention the fact that, I think this has been mentioned by David, that I've had the opportunity to visit basically 95 or more % of the health facilities in the country. This including public hospitals and also what we call PNFPs. PNFPs are private, not-for-profit. These are usually founded by the churches. And so I have the opportunities, I've had the opportunity to visit these facilities and get a sense of what is happening there and talk to people working in there, especially my students who are students of health administration. Now, this has taken many years, since 1997. I haven't done this over 1 year, it has been over a long period of time. Now, the slides will guide our discussion, and the focus of these slides is showing there the context, some information about the context about Uganda, and then some overview of Uganda healthcare structure, brief history of human resources for health in Uganda, the current situation, the challenges, what is being done, and then conclusion. So the slides are about 30, but that is the overview of the content. Sorry. Now, I use PowerPoint quite often, but I don't use this gadget so much. So when I press the wrong button, please forgive me ahead of time. Now, I know that you know where Uganda is. It is in East Central Africa, south of the Sahara. And that this map gives you an idea of the location of Uganda. Now, one of the things, of course, that I usually mention to people who haven't been to that part of the world is that we don't have seasons so much. It's either dry or wet, and the day is roughly 12 hours and the night 12 hours. And we don't have winter, we don't have summer, we don't have, it's just those. The population of Uganda is 35 million, and now that may not sound a huge number, but when you look at the area of Uganda is, I just discovered Uganda is a little bigger than North Carolina. It's almost about a quarter, roughly about a quarter of a million square kilometers. North Carolina is less than that. Most of the population is rural, that is 84%. Now, that statistic, the population growth rate is very high, 3.4%. They say that that's about the second fastest growing population in the world. And based on that statistic and the current population base, roughly every year there is an additional 1 million Ugandans. Now you can compare the population growth rate of Uganda with that of the world, which is roughly 1.2, and that of the USA, which is only 0.7. So that contrast you can see. Total fertility rate, I'm sure you're familiar with that index, which is just the total number of women on, total number of babies on average each woman in Uganda has. Now, each woman in Uganda has 6 to 7 children. I looked at the statistic for the USA, it is less than 2 children per woman, and for the world is 2.4. So you can see Ugandan women are very fertile. Well, the women are fertile, but the men are also fertile. You can't have only women's fertile. Fertility is important. The total areas I've mentioned, roughly 250,000 square kilometers. Now compare with North Carolina, it's 139, with a population of 10 million. So Uganda's population density is quite high. GDP per capita, that's only $547 US. I'm sure you understand what that statistic means. I compared that with that of the neighboring country, Kenya. Kenya's economic situation is a little better than that of Uganda, so they have $862 US per annum. And that of the USA is about 100 times that of Uganda, so there's big differences. Now, most frequent cause of morbidity is malaria. Malaria is what causes up to 50% of morbidity in Uganda. But there are other infectious diseases. I'm sure you know about HIV/AIDS, gastrointestinal tract infections, and other infections. But also, non-communicable diseases are becoming a serious issue there. Diabetes, high blood pressure, cancers, and others. And accidents. Those of you who've been to Uganda, you know the culture of driving there is very different from what I see here. And so accidents on the road are very frequent, but also accidents in industries and other places. The proportion of national budget devoted to health in Uganda, the most recent budget, which is July 2013 to June 2014, 8% of the budget, and the budget is about $5.2 billion US. So 8% of that is devoted to health. But I want to mention here that that's in theory. When they are reading the budget, they may say something to that effect. But in practice, you find that if there is a shortage, usually what they do is they cut from health, from education, and fund other areas that are priority to the leadership, like defense and other government businesses. So 8%. Now, I also want to mention here that in 2000 or 2001, African leaders sat in West Africa and came up with a decision that governments should spend about 15% of their budgets on health, African governments. They call it Abuja Declaration. But very few governments have kept that. Uganda is definitely far from that. Per capita expenditure on health is only about $42 US. Now you can compare that with Kenya. Kenya is spending less. Rwanda is spending more. And I also compared that with USA. These numbers are for 2011 in the World Bank data, but you can see the contrast there. Now, of the $42 that are spent per capita on health in Uganda, government provides only about $12. The other money comes from out-of-pocket expenses and donations from donors. Let's look at the Uganda health system. It is decentralized. What generally we mean by this is that the country is divided into districts. Right now there are 112 districts. And each district is responsible for prioritizing, planning, and delivering health services to its people. But the prioritization is guided by a national health strategic plan. So priorities are aligned with the national strategic plan. And so that's what is happening there. I've already mentioned we have 112 districts, and these are increasing in numbers. There is some political interest in increasing districts by the politicians. But when it comes to health services delivery, it's a challenge, because when you think about it, each of those districts is supposed to have a medical officer as in charge of health services. But you find that some of the districts actually, some of them do not have a single medical officer. So the country is being subdivided. The intention is to bring services closer to the people, but it's actually not happening. In many cases, in some cases it is happening. Now, so each district has a general hospital, and each district is also subdivided into counties and sub-counties and parishes. And at each of those levels, there is supposed to be a health facility. Sometimes it's there, sometimes it's not there. So what I'm communicating here is if we have 112 districts, then we will also have 112 general hospitals and more health center level 4, because there will be several health centers level 4 in each district, and many more health centers level 3. A health center level 4 is like a mini hospital with a theater where some surgeries like cesarean sections and other lighter surgeries can be performed. A general hospital is a little bigger with a theater where bigger surgeries can be done. Now, in addition to those general hospitals, we have what they call regional referral hospitals. Now, each of these regional referral hospitals may have a bed capacity of between 200 to 600 beds, and each of these hospitals serves a cluster of about 12 districts. Now, there are also 2 national referral hospitals. Some of you who've been to Uganda, I'm sure you visited Mulago. The second national referral hospital is Butabika, which was originally a psychiatric hospital, but now also has a general wing. So that's generally it. Now, that is what it looks like. Looking at the, sorry, I thought I would have a pointer pointing at, but generally this is a reflection of what is happening at the level of one district. If you look at general hospital, down in the middle, upwards, those are divisions in each district. So you will have clusters like that, 112 of them. It will give you a rough idea about the healthcare system in Uganda. Now, human resources in Uganda. I wanted to start by referring you to that statement, which appears in the World Health Report of 2006. That's a bit old, but it's a true reflection of what is happening generally in Africa. And it says that the WHO region of Americas, this includes USA, North America, South America, with 10% of the global burden of disease, has 37% of the world's health workers, spending more than 50% of the world's health financing, whereas the African region, on the other hand, has 24% of the burden of disease, but only 3% of health workers, and spending less than 1% of the world expenditure on health. That represents what's happening in Africa, particularly in Africa south of the Sahara. Now, a little bit about the past of human resources for health in Uganda. The first training of Ugandans as African medical assistants was in 1917 at Mulago Hospital. These were medical assistants, not doctors. So that was the first training. And then midwives a school was opened at an old hospital. Mengo Hospital is the oldest hospital in the country. Started way back in 1897, I think. And that's where the first nurses were trained. And then the first medical school training doctors was opened in 1924 at Mulago. Now, you can see between 1924 and 1989, we had only one medical school. But then in 1989, another medical school was opened in southwestern Uganda, and now the country has 4 medical schools. Now, in the earlier years, before the 1970s, they say, this picture says, that we had one of the best health services south of the Sahara. The hospitals were few, but they were functioning well, they were well funded, and actually most of the money funding these hospitals that time, funding the entire health services that time, came from local sources. But after that, it came, and then there were global events like global recession. Those of you who are young, you may not know about Amin, but Amin was a dictator who overthrew a democratic government in 1971, I think. This was an illiterate dictator who was also a soldier. He took over government and decided to run it in different ways. The economy was run down. They started killing elites, including especially doctors, engineers, lawyers, and other people whom he perceived well. So doctors and other highly qualified people ran away from the country. That was the beginning of severe decline of the health system in Uganda. That was in the 1970s. So let's look at numbers. Now I'm moving fast. I hope that is all right. I'm hoping that we will have a bit of time to talk. Numbers, Uganda has an estimated 70,000 health workers. That's according to the Ministry of Health, and these include doctors, nurses, midwives. So that number is big, but it is a mix of different kinds of people working in the healthcare system. Now, the density of health workers in Uganda is 1.8 per 1,000 people. Now, WHO recommends a minimum density of 2.28 to achieve the Millennium Development Goals. So we are below the minimum required, and the reason we are classified as a country with a critical shortage is because of that statistic there. And that is, the 1.8 is an improvement. Now, looking at the entire public health system, the percentage of approved posts that were filled by 2012 was only 58%, according to the Ministry of Health. So if we had 100 posts, only 58% were filled, and sometimes filled with unqualified people. Now, just before I left Kampala, I came across some data fresh from the ministry saying that this had improved to about 70%. So they say it is improving, but it's still low. Okay. Now, partly the high vacancy rate is due to a growing number of districts, and the most affected are the lower level. Now, in this graph, you can see that the bigger hospitals, purple and blue. Purple are the national referral hospitals. Those are better staffed. Blue are the regional referral hospitals, the 13 hospitals which I mentioned. Those are also better staffed because they're in better locations, they are better funded, they have better facilities, and generally health workers stay there a little longer than in the lower health facilities, which are rural and much less funded, and with less equipment, poor housing. So that is the picture. The lower you go into the rural areas, the poorer the staffing. And yet the majority of Ugandans are actually, as we saw earlier on, they are located in rural areas. Okay, nurses, there are 27 nursing schools in the country, and the population of nurse midwives per population is better than that of doctors. It's 13 per 10,000. To date, there are those numbers of nurses in the public facilities. In the private facilities, we don't have accurate numbers. The records are not accurate. Doctors, as I mentioned earlier, there are 4 functional medical schools. The old ones established earlier on in 1920s, and then between 1989 and now, 3 others came up. And by July, there were about 4,000 doctors registered in Uganda. But they were not all practicing there. The doctor-to-patient ratio is estimated to be about 1 in 10,000, and literature says WHO recommends 1 in 600. Now, of the 4,200 registered, only around 1,200 are practicing in Uganda. And this is what I was thinking about when Professor Michael was taking me through the hospital here, and he mentioned that the hospital here has about 1,005. To me, that was mind-blowing. I just couldn't understand that. One hospital, you have more doctors practicing here than we have in the entire country of 35 million people. Now, over the past 10 years, about 2,000 doctors have left Uganda, and they migrate to neighboring countries, South Africa, Southern Sudan. Now, I'm sure you people know Southern Sudan is a new country, about 3 years old, but I don't know how they are better able to pay. In fact, looking at a slide down, you will see that Southern Sudan pays better than all the other countries in the region. Okay? So I want to look at so the message in these slides is that, well, the doctors are moving away, but even if all the doctors were in Uganda, we don't have enough numbers of doctors and nurses and other health workers. Okay. So we are training about 300 doctors per year. There are 300 medical students are recruited per year, but only about 260 doctors graduate each year in Uganda, and it is said that about half of those, they leave the country. Now, Joseph is here, my son's friend, and I don't know whether after the training here he will go back home to Uganda. I'll talk to him and find out. But many of them go and do courses in other countries, and they get registered there, and somehow they don't come back home. Okay? But I don't blame them, because the situation is very challenging. Now, factors that are pushing doctors away from Uganda. Compensation is one of them. The quality of management, the availability of equipment and supplies, the quality of facilities. Now, those of you who've been to Uganda, you've visited facilities, especially rural facilities. The facilities are discouraging. There isn't enough for a trained person to use to do their work well. And so these are all factors that push doctors away from Uganda, all that list. Okay. But top on the list is compensation. Now, the psychologists tell us that money is not the top motivator. But
I'm sorry to interrupt you, but I have a question. When you talk about medical schools, do you mean doctors only, or the training facilities for nurses also?
No, that was only for doctors. For nurses, we have 27 nursing midwifery schools. For doctors, there are 4. Yes. Yeah, I was saying that money is not known to be a very strong motivator. But if you don't have enough to meet the basics of life, then it becomes a motivator. If you don't have enough money to put food on a plate, you don't have enough money to pay tuition for your child or to buy clothes, then it becomes a motivator. And so that's why it is appearing top on the list there. Now, this table here gives you an idea comparing the payments in Uganda with the payments in the surrounding countries. A doctor freshly graduated like my son, Joseph there, if they went to work in a public facility and on government payroll, their pay would be about 846,000, not dollars, shillings. And the exchange rate is $1 is 2,600 Uganda shillings. So a payment of 846,000 is about $300 per month. Now, same doctor working in, say, Southern Sudan, on my right, your right, the payment would be like more than 10 times. Not 10 times, I don't know how many times that is, but maybe six times. In Rwanda, you can see it's much better. And then consultants, senior consultant in Uganda, they will receive 2.3 million, which is less than $1,000. In Southern Sudan and in Rwanda, they are paid much better, something like 4 or 5 times. So this is discouraging. It is very difficult to survive decently on $300 or even less than $1,000, because by the time you become a senior consultant, you have children going to school, you want to drive, even if it's a small car, but you don't want to be running around on borders. We have what we call borders there, you know, but these are motorcycles which you can hire and sit on. They are dangerous and the environment. So this is very discouraging, and it causes health workers to move on. Other pull factors, well, those were push factors, pushing health workers away from Uganda. Pull factors include globalization. It's a lot easier for people to move from one country to another, and somehow they do examinations, pass them, and they go into other countries' health systems. Many Ugandan doctors are in Australia, in Canada, in Europe, and so they are pulled there. And of course, the aging populations of developed countries, increasing specialized and new medical technologies, all these are pull factors. Let's also briefly look at distribution of health workers. I think that I'm running out of time, but what I want to mention here is that the majority of health workers prefer in the big urban areas. There are not so many, and so most of them are in the central region around Kampala. Kampala is the capital of Uganda. Now, there are few, but the majority of them are in the city, and the majority of the population is in the rural. So that's a problem, that distribution. And in fact, some districts don't have even a single physician. You may find a hospital there where there is no doctor to run it. Now, the shortage, according to predictions by WHO in Uganda, a shortage of doctors, nurses, midwives is likely to continue. Those are projections. The dotted line is based on the current resources and numbers, projections by Ministry of Health. Now, the upper blue line is by WHO. If we are to meet the Millennium Development Goals, currently we are not meeting them. One of the reasons, leave alone other resources, we don't have enough human resources. But also, even in the future, you can even see the gap is widening. And so that's a challenge. Now, the challenges in management, some of them I'm sure you picked them along the way: limited funding, inadequate distribution, inadequate tools and equipment, the shortage of people, very low wages. Now, there are other challenges that are related with attitudes of health workers. When health workers are not properly treated, they develop a poor attitude towards their work. So that's another challenge. Okay, shortage of role models is also an issue, because people, those who, graduate and gain experience, many of them run away. So we don't have many role models for young, upcoming, health workers. So all those are challenges. What is being done? There is now some efforts to improve data, records, information about, so that they can be tracked, so that they can be followed and maybe guided in some ways. the Ministry of Health is making effort to have an information system where you can know where which health worker is at what time and what are they doing. And this is being supported by USAID. There is a human resource policy earlier on that wasn't there. And the policy encourages collaboration between the government, health development partners, and other organizations to manage and attract human resources for health. And at the Ministry of Health now, there is a working group focused on human resources for health management issues. And there is also some efforts to improve the incentives introduced, like beginning, I believe, July this year, medical officers working in the rural health center level 4s, they are being paid like $2.4 million, which is about $900. I don't think this has really started, but the effort is there so that people can feel like they are valued, and so that maybe much of their expenses can be met. And there's been also efforts to recruit more, but you know, recruiting more without improving the working environment may not work. So in conclusion, Uganda has a critical shortage of humans. You can see the numbers. We do have a critical shortage. Payments are a big issue. The working environment is a big issue. And there is also need for the leadership to change their attitude towards the healthcare system and especially health workers. Okay, some questions, yes?
So what are the competing priorities for the government?
As a layperson,
Yeah, right.
I would say that government has tried to put more resources on defense. A lot of money is spent there. But also they are trying to improve infrastructure. The roads, they are trying to build more roads. They are trying to build more hydro dams. So that is where the priority is. And this is being seen as a consumer sort of, so they're spending less, and even the less allocated, when there's a gap elsewhere, they will take away and try to fill that gap.
Can you say something about the roles of FBOs and Christian health associations in
Faith-based, yeah. Actually, that doesn't appear very clearly here. But I want to mention at this point that the healthcare system, as I showed it there, includes faith-based facilities. They are in there, and some of the district hospitals are actually faith-based hospitals. And these hospitals, the overseer is the government district medical officer, although they have a different system of reporting and management through medical bureaus and the founding organizations. So, and the other thing I want to mention about faith-based organizations and what we call PNFPs especially, is that almost 50% of, if you are to talk about the volume of services given in the healthcare, is given by these facilities. And actually government tries to subsidize them. They give them some contribution towards their budget. And some health workers are actually seconded by government into those facilities. Yes?
I think on one of your first slides, you accounted for about half of the morbidity due to malaria.
Yeah.
Why do we need to worry about more doctors then? Shouldn't we be focusing on healthcare workers, midwives, perhaps nurses? If really the morbidity, really the real health issues in Uganda are things that you don't need a doctor for. And in fact, you've wasted a lot of resources training doctors when you could have trained 4 or 5 other healthcare workers.
Well, I think that's a good observation, and indeed there is effort. When you look at the efforts towards improving the health services in Uganda, there is effort to improve and make it possible for what is called community health workers to play more role at community level. And so yes, that is recognized. But at some point, you'll still need nurses, you'll still need midwives. What I haven't mentioned here, for example, is that the maternal mortality rate in Uganda is 438 maternal death per 100,000 live births. And so that's very high. In here, I think you have less than 10 per 100. So you still need midwives, you still need nurses, and you still need hospitals. But there is effort to improve at the lower level, and government has actually tried as much as possible to build more health centers 2, health centers 3, health centers 4, and general hospitals, because these are rural-based, and most of these cases of malaria and other infectious diseases should actually go there before they go to the national referral hospitals to crowd them. So that is recognized, but still you will need trained health workers at all levels, and that's a challenge.
Look, can I just follow up? So the issue with the high maternal mortality in Uganda is also an issue that can be addressed before you need a doctor. So much of that is about access to care, prenatal access, right? And then a lot of the mortality is due to when women present at these health centers who've already advanced and have complications that could have been addressed much earlier. And then, you know, the recent cases about women being turned away who aren't able to pay healthcare workers to offer them services, right? So I don't know, I really strongly feel like the focus should be on much lower level training, many more people, and not really worrying about doctors.
Let me just throw something out, because I've had these sorts of discussions, and so when I was just there a few weeks ago, I visited this hospital, a very rural hospital, it's a Catholic hospital in a town called Napayer in West Nile. And I was visiting it with the man who started it in 1987. When he arrived, it was a health center, and there was no hospital anywhere even close. And so he was there for 14 years, and in that time he turned it into a hospital. And when I first asked him, I asked him, so you know, you arrive, it's a health center, you turn it into a hospital. First of all, why? And secondly, how did you do that? Like, what's the first thing you had to do? And his response was, well, the first thing I did was I built an operating theater. And I said, why? I mean, to me, that wouldn't be obvious. And he said, 2 reasons. He said, first of all, in Uganda, people expect, if you're a doctor, they expect that what you do is surgery. That's what makes you a doctor. You can correct me if I'm wrong. But secondly, he said, we're very remote. And so I was looking at what was killing people. Now, not killing them in general over the long term, but what was killing them that really was immediate. And it was surgical things. It was C-sections. It was twisted intestines, gastrointestinal things that needed immediate attention. And he said, so I knew that with a malaria case, they had the time to get to a facility. But where I was, with many of the conditions I was seeing, they didn't have the time. So the first thing I did within the first 3 months is, he said, I built just a makeshift, really, operating theater. And he didn't intend to operate in the first 3 months, but an emergency case came in and he had to. So in that sort of situation, I mean, this is now, I think this hospital now serves about 300,000 people. There are only a couple of physicians there, so it's not as if, so me it would be a both and, I guess, when I talk to him, that if you don't have surgical capability, I mean, you could just run the numbers and say you're still going to save more people if you just attack malaria. But if you're actually living in these settings where the people are coming in with these emergencies, if you don't have surgical capabilities, then a lot of people are just dying. So that's at least how he explained why he built it that way.
But I don't think the numbers support that logic. The evidence is really clear. What the morbidity and mortality is in Uganda can be addressed with much lower level training. Just let's triple it or quadruple it. And besides, you're spending all this money to train Ugandan physicians who leave. If you train midwives and community health workers, they're not going to go to Kenya.
The midwives, the nurses, with good qualification, they will still go. In fact, it's not really a joke, but they say that most of the midwives in Uganda are running shops. So there is some midwives trained there, but because the working environment, the attitude towards them, the facilitation is not good. So instead of going to hospital, they are downtown Kampala buying and selling pieces of cloth. So the issue of motivation and improving the environment and the attitude towards them, even the community health workers, you still need to think about how do we motivate them, how do we encourage them so that they can pass on the basic information that is needed by the community, so that someone knows when they have malaria, instead of taking a herb, they should go to a health center and get the correct dose of Coartem or whatever they need to have the malaria. So we still need to look at not only doctors actually, maybe here I emphasize doctors, the entire spectrum of health workers, right from the community health worker, the driver who drives an ambulance or any other vehicle for the hospital. But what you see here is a reflection for almost all the other categories, where it may differ in some ways in the sense that some of the numbers in the other categories, like you may have more nurses, but are they motivated? Are they facilitated? Do they have what they need to function as nurses? Those are the questions that one would want to ask the people who are in authority and the people who drive things.
Edward, thank you for a very nice talk. There's some evidence that if you select medical students from rural areas, that they may return to practice in this environment. Is that part of the selection process for medical students in Uganda?
No, that is not there. But related to that, the second medical school at Mbarara was established with that in mind, because Mbarara then was much more rural than it is now, and the training, the curriculum was designed in such a way that these doctors, the trainees, spent more time in rural areas doing, community things. The thinking was that they would be more likely to work and stay in rural areas. But over the years, I don't have a well-researched paper on this, but the observation is, as they become better doctors and get better qualifications, they actually move towards the towns and eventually out of the country. So it will happen. But they may take a little longer working in places a little far away from the towns. And maybe as we get more medical schools and we recruit more, because 300 per year is a small number to divide them that way. But as we get more, and there's a 5th medical school in opening soon, maybe we will look at it from that angle. I saw a hand going up here.
Mukooza, the informatics system that you were talking about earlier, does it track non-integrated healthcare providers as well? So for instance, if some visiting provider, some visiting subspecialist came to Uganda, they would have to register with your system and tell your government where they're working, what interventions they can provide.
Yeah, if you're going to work there for some time, you would have to register. And actually, I came across some information that suggested about 25% of the, for doctors registered in Uganda were, foreign. They were there for a while, but it wasn't possible to tell for how long they would be there. So you need to register if you are going to work there for some time.
Edward, let me ask you a question about since you teach health administration, and in some ways this is going back to Carrie's question about doctors. So when I was visiting this hospital, I met, and I've told you this, so this is sort of just to see if this is a microcosm of talking about the larger issue of the administrative parts of the system and where the administrative expertise and skills exist and how those are being shored up. So the young man who was running this hospital was in his 4th year out of medical school. So that means he's 27 years old. He was just starting his 4th year as the medical superintendent of this hospital. It's a 130-bed hospital. So he's in charge of running the hospital. He's only in his 4th year out of medical school, and as we talked way over, I mean, in Uganda medical school, you start as a bachelor's student. So really, that's why he's so young. He's 27 years old. So he's now charged. So he's the chief surgeon. He's running a 130-bed hospital, and because he had no management training in medical school, but is now running a hospital, every weekend he was going into Kampala to get a degree in health management, and that means that on Fridays he was getting on the bus, traveling 10 hours to go to classes on Saturday, and then get back on the bus to go back to the hospital on Sunday. He was doing this every weekend. And one of the things I've run into in working in the management parts of Uganda is the assumption is that the person running that hospital needs to be a doctor, that doctors run things. And I think that's probably mimicked here as well, right? So one of the questions, and yeah, actually in the health management teaching that you do, I think most of your students are not doctors. They're actually the nurses and the midwives and the clinical officers. So there is a gap really between the assumptions that the doctors are the managers and the reality that, at least in your teaching, you're actually working with the other level of people. And also, I mean, that's just an interesting story, because it would be unimaginable in the States that we would have a 27-year-old person in their 4th year out of medical school running a hospital, and also being the chief surgeon and doing all of the practice. So what does that look like at the level of the management of the system as you work with these students? And
well, what I can say is that that has been in the system for many years, that people in leadership in the healthcare system have to be medical doctors or senior nurses. And I think that we are beginning to realize, we should have realized this long time ago, that this should change. And in fact, because of the shortage, sometimes you actually find that, first of all, you find a hospital without a doctor, and therefore there is a hospital administrator who is not a medical doctor running it, but it's not really running as a hospital, because in Uganda, if there are no surgeries, then that's not a hospital. Now, at district level, all the district health officers, by policy, they were supposed to be medical doctors. But now you find quite a few districts whose leader, the DHO, is in acting situation and is not a medical doctor. And I know quite a few districts where the acting medical officer is not a medical doctor and has been in that position for up to 5 years. So because of the shortage, it is changing, and it is forcing those in leadership to realize that actually it's not necessary, because some of the districts that are led by people who are not medical doctors are actually functioning better than the districts where you have medical doctors in leadership. So I think, well, it sounded like that was a comment, but the thing is, I think eventually we are realizing that you don't need a medical doctor to be the health officer of the district. And I think eventually we may also realize that you don't need a medical doctor to be the chief executive officer of the hospital, because they end up spending more than 80% of their time on administrative and leadership things, which most of the time they've never learned. They've qualified as a surgeon, and then suddenly they are made the executive director of a regional referral hospital without any management training. And so the first year or so they mess up things. And I don't know whether I've responded to your question, but that's the experience now.
For just a few minutes left, does anybody else have any other questions?
You mentioned that a lot of the doctors leave because they're not paid enough. How tight is the pay scheme run by the government? Because I know that in Kenya there's a big problem with corruption and funds kind of disappearing. Is that a similar problem in Uganda?
I want to say that the reasons doctors leave, yes, top on the list is payment, but also it's a combination of factors. Payment, one. Two, the working environment. If you go to a hospital and you don't have equipment to use, then you feel useless. Or if you don't have what you need to do your work well, that discourages them. And of course, there are other factors, like if they want to advance in their career and they don't have opportunities, those are things that drive them away. You're talking about corruption also. Corruption partly explains why we don't have enough resources to provide public services. A lot of money is stolen by people in leadership, and I feel shy to say this, but Uganda is one of the most corrupt countries in the world, as you may know that. And not all of us are corrupt. I don't think I'm corrupt. It's usually the people in big leadership positions. Now, health workers, you could say, in a way, they are forced to be corrupt. Why? Because if you're sent in a regional referral hospital to work, and you are paid 20% of what you need to go through your basic needs in a month. So you are forced to find a clinic or another facility where you work. You're supposed to be here full time, but then you work for a few hours and then go, they call it moonlighting. I'm sure you've heard of that term. And I think that's also a form of corruption. But they are forced into that situation. So money is stolen by leadership, and this is something that is documented everywhere. And one of the reasons why the economic situation now is declining faster than it should have been is because donors are upset with our leaders. And many donors have withdrawn donations because they say that we're donating money and a few people are stealing it. So that's a big challenge. Yeah.
And following on from that, in the new policy that they're implementing, the human resource policy, is there more of like an accountability structure in terms of reporting cases, or because sometimes people don't want to report cases concerning their supervisor because they're afraid that they'll lose their job or something. So
We are talking about like if there is some kind of negligence or malpractice.
Yeah, because
that is there, and there is a strong council that oversees what the doctors do. And in fact, recently I left some cases in Kampala where doctors were being, prosecuted for doing wrong things. I don't think that is a very big problem. The problem is with the politicians who handle and process the funds.
Yeah.
That is where the problem is. But if doctors and nurses and other health workers are put in a place and they are given what they need to work, there may be a few cases of, indiscipline, but I think that they will generally do a good job.
So we're out of time, so join me in thanking Dr. Mukooza.